Today is all about inpatient correction insulin sliding scales. This is the 7th video of the inpatient diabetes management course. A link to the full course is provided below. Before we start, remember to sign up using the link below for PDF summaries of this video and future videos on the channel. The summary is usually delivered to your inbox 24 hours after the video is released on the channel. In case you don't find the email in your primary folder, check your spam or promotion email folders and make sure to move it to the primary folder. In this video, we will discuss the following. What's the inpatient correction insulin sliding scale? What type of insulin should be used in the correction insulin sliding scale? The problem with these scales, the sliding scales, why do we use them? How to use them in clinical practice? And we will finish with how to create or adjust a correction insulin sliding scale. I will be providing you with real-life clinical examples throughout the video. Let's go. The correction insulin sliding scale is to give insulin as needed for hyperglycemia. Simply, we create a set of predetermined insulin amounts to be given for a specific blood sugar range at a specific time. The insulin dose or amount progressively increases as the blood sugar value increases. Take a look at this self-explanatory real-world settings insulin sliding scale. So what's the purpose of inpatient correction sliding scales? These scales are created for different reasons. To help us estimate the adjustments needed for the patient's basal/bolus premeal insulin coverage, and to speed up the response to hyperglycemia and makes it easy for our nurses as they don't have to report each value to us. But by no means the insulin sliding scale is perfect. It has the following shortcomings. The same scale is often used for different patients regardless of their individual insulin requirements, as it bases insulin doses on glucose levels prior to meals without regard to a patient's basal metabolic needs, the types and amounts of food to be consumed, the patient's weight, or other factors influencing insulin demand such as previous insulin needs, insulin sensitivity, or resistance. For example, a patient weighing 80 kilos would receive the same insulin dose as a patient weighing 65 kilos if their blood glucose levels are within the same range. Subsequently, the 80 kilo patients may not receive sufficient insulin, placing him or her at increased risk of hyperglycemia, and the 65 kilo patients may receive a potentially excessive dose that could result in hypoglycemia. Also, rather than being proactive in preventing hyperglycemia, sliding scales insulin regimens are reactive and work to treat hyperglycemia after it has happened. Another problem as well with the insulin sliding scale is that patients do not receive insulin when their glucose level is normal, and within a few hours their glucose level increases, leaving them with long periods of hyperglycemia without any treatment. That's why we always recommend against the solo use of insulin sliding scale in inpatient settings, with few exceptions. I will discuss that soon. In general, any PRN or as needed medication should have a rapid onset of action and dose based on its half-life. Short or rapid acting insulin is the insulin used in the correction sliding scale because it's as needed insulin, right? And that's why the correction insulin sliding scale should be dosed every 4 to 6 hours or before meals and at bedtime, or what we call ACHS. Human regular insulin is the preferred insulin if the correction sliding scale is dosed every 6 hours or ACHS, given its half-life is a bit longer than insulin analogs. And by analogs, I mean here insulin lispro, aspart, and glulisine. I discussed all of this in a previous video in this course about insulin. On the other hand, if the correction sliding scale is dosed every 4 hours, both insulin analogs or human regular insulins can be used with no preference. I want to remind you that for scheduled premeal insulin, analogs are the preferred ones over human regular insulin. Here we are specifically talking about the correction sliding scale, not the scheduled premeal insulin. By the way, if you're enjoying this video so far, I would love it for you to give us thumbs up. Apparently, it really helps with the YouTube algorithm. Let's now move and talk about the uses of correction sliding scale in inpatient settings, and we'll start with type 1 diabetes patients. In type 1 diabetics, the insulin sliding scale is typically an add-on therapy on top of scheduled insulin therapy and should never be used alone, even in NPO patients or those with poor oral intake. Remember that all type 1 diabetics should receive basal insulin whether they are NPO or not. So please do not use insulin sliding scale alone for type 1 diabetics. For type 1 diabetics patients who are NPO or have poor oral intake or unpredictable oral intake, a correction insulin sliding scale can be used along with a reduced dose of basal insulin, roughly by 50% of their original dose. No scheduled pre-meal insulin should be used in these patients. Now, for those type 1 diabetic patients who are not NPO and have adequate oral intake, a correction sliding scale is used along with basal insulin and the scheduled pre-meal insulin. Some may get confused here, but yes, we give the scheduled pre-meal insulin and extra insulin per sliding scale. Type 1 diabetic patients who are on insulin pumps should continue to use their own insulin pumps without interruption unless an insulin drip is required, where the pump in such a case should be switched off. These patients should also continue using their carb count based sliding scale on top of their basal infusion rate. Again, I explained this in my previous video in this course about insulin. If they are NPO, we cut the basal infusion rate by roughly 50% and replace the carb count based sliding scale with our inpatient or with one of our inpatient sliding scales. If the pump is not functioning or is empty, the patient should be started on scheduled basal insulin along with scheduled pre-meal insulins and a sliding scale if the patient has adequate oral intake. If the patient has poor oral intake or NPO, we should just have a basal insulin and a sliding scale as we explained earlier. Let's take a real-life clinical example, as nothing like a real-life example to clarify all of this. Patient A is a 22-year-old lady with type 1 diabetes on insulin Detemer 15 units sub-Q twice daily and insulin Lispro 8 units before each meal. She presented to the emergency department with flank pain, fever, and vomiting. She was diagnosed with acute pyelonephritis with no evidence of DKA or hypoglycemia. She was given IV fluid and antibiotics, and you were called to admit this patient. How would you approach her inpatient diabetes management? Patient A is clearly acutely sick with pyelonephritis, and likely her oral intake will be diminished for the first 24 to 48 hours. On admission, I will do the following. I will reduce her basal insulin by 50%, suspend her scheduled pre-meal insulin, and start a correction sliding scale. So her insulin regimen on admission going to be as insulin Detemer 8 units twice daily plus a correction sliding scale. 2 days later, the patient is feeling much better and her oral intake is almost back to normal. You are planning to discharge her in the next 24 to 48 hours. Would you change her current regimen? Given that she has now an adequate oral intake, her scheduled pre-meal insulin can be safely resumed at the same or reduced dose based on her blood sugar readings. And I will keep the correction sliding scale, so her regimen going to be as insulin Detemer 8 units sub-Q twice daily plus insulin Lispro 8 units before each meal plus correction sliding scale. Remember that diabetes management is a dynamic process that requires continuous monitoring and adjustments. The next day, she was feeling 100% better and you decided to discharge her on oral antibiotics. She asked you if she should continue the current inpatient insulin regimen or resume her home regimen. At this point, it should be safe to resume her home insulin regimen without any adjustments. Let's move to the use of correction insulin sliding scale in type 2 diabetes patients. Type 2 diabetes patients who are on insulin-based therapy at home are treated similarly to type 1 diabetics as we just explained. So let's shift our focus to those treated with non-insulin diabetic medications. In these patients, the correction sliding scale can be used as an add-on or as a solo therapy. If the patient is NPO or has poor oral intake, all non-insulin diabetic medications should be suspended and a solo correction insulin sliding scale can be used in such a case. For patients with well-controlled diabetes at home and adequate oral intake, we resume their home non-insulin medications and add a correction insulin sliding scale. In patients with poorly controlled type 2 diabetes, non-insulin medications should be again suspended and an insulin-based therapy should be initiated either with a continuous insulin infusion or what we call insulin drip, or by initiating a basal/scheduled pre-meal bolus insulin along with the correction sliding scale. As you might have noticed, we're only talking here about the initial strategy of inpatient diabetes management. I repeat what I just said, that blood sugar control is a dynamic process and require continuous monitoring and adjustments. So all these strategies probably will be adjusted based on the inpatient blood sugar readings. So how do we make or create an insulin sliding scale? To create a correction insulin sliding scale, we need to specify the following: the frequency or how often we give it, the type of insulin to be used, the minimum minimum value at which the scale coverage starts, the blood sugar increment value with each range, the maximum blood sugar value at which the scale coverage stops, the amount of insulin or starting insulin dose, and the amount of progression or increment with each range. To clarify all of this, let's bring the previous correction insulin sliding scale example. In this example, the frequency is before meals and at bedtime, or ACHS. If the patient is NPO or on continuous tube feedings or TPN, total parenteral nutrition, then the frequency can be adjusted to Q4 hours or Q6 hours. If blood sugar values are falling within or close to our target of 140 to 180, ACHS or Q6 hour scales are acceptable. While if blood sugar values are persistently and significantly higher than our target, a Q4 scale is preferred. Remember, in critically ill patients, it's better to switch them to continuous insulin infusion or insulin drip. Now, one trick we can use with the sliding scale is if I want to treat critical hyperglycemia. When I say critical, that means blood sugar more than 300. Without using an insulin drip, is to use the correction insulin sliding scale Q1 to 2 hours until the blood sugar drops below 80. So if your patient is on the floor, you may not be able to do more than Q2 hours insulin sliding scales. In the ICU, can use the Q1 hour. So let's say that patient B is using the sliding scale we just mentioned in the example, and his blood sugar was 370. We could adjust the frequency of the scale to Q1 hour in the ICU or Q2 hours if in the floor. The patient should receive 10 units of human regular insulin, then repeat blood sugar check in 1 hour and give whatever amount determined in the scale, and we keep repeating until blood sugar fall to our target, usually less than 180, then switch back to the previous frequency. So now we decided on the frequency. Next, we decide what type of short-acting or rapid-acting insulin to use. All hospitals carry human regular insulin and usually one brand of rapid-acting insulin, mostly insulin Lispro, Humalog, or insulin Aspart Novolog. This leaves us with two choices here: human regular insulin or Humalog or Novolog, whichever is available at our facility. In this example, human regular insulin was used, and again I want you to remind you here that for scheduled pre-meal insulin, bolus insulin, insulin analogs are preferred over human regular insulin, while for correction sliding scale, human regular insulin is preferred over insulin analogs, especially if we're doing the scale every 6 hours or ACHS, given its longer half-life compared to insulin analogs. Now, the minimum blood sugar value in this example was 150, the increment was 50, and the maximum value at which the scale coverage stops is 400. In clinical practice, I don't recommend going below 120 as a minimum value or higher than 400 as a maximum value. So you may start at 120 or 150 or 180 or whatever you like and go as high as 300, 350 or 400. In this example, 2 units of regular human insulin was the starting insulin dose for the first blood sugar range. The increment was 2 units, which means we increase the amount of insulin by 2 units with each range. You could start with 1, 2, 3, 4, 5 or 6 units as a starting point and then increment by again 1, 2, 3, 4, 5 or 6. The higher the starting dose and the higher the increment, the more intense the scale is. Let's say we want to intensify the sliding scale we just used in the example. There are different strategies to do here. First, by reducing the blood sugar value, the starting blood sugar value at which the scale coverage starts, or by increasing the starting insulin amount, increasing the increment, or both, or by doing all of these together. Let's intensify the example sliding scale using strategy 1. So the scale will look like this. And the scale will look like this if I use strategy 2. And like this if we use strategy 3. The bottom Bottom line, these are all just general guidelines, but you can adjust your patient scales the way you want to help achieve adequate blood sugar control. Now, the good news is most hospitals have different intensity sliding scales already populated in the system that you can just pick from or even customize. At the end, I hope you found this video useful. If so, please give us thumbs up and share it with your colleagues. The next video will discuss continuous insulin infusion or insulin drip in clinical practice. Thanks for watching and see you soon.